Yeah, and thanks for the invitation. This is a marvelous program, and I'm so happy to be sandwiched between two of my favorite and most influential colleagues, between Ilya and Josh. So thank you for this opportunity. I'm going to build a little bit on what Ilya talked about in terms of integrating radiation, in his case for metastatic disease, and we're going to talk about the primary tumors. In 1977, Enneking Classification was developed to determine treatment for musculoskeletal tumors. They identified significant prognostic factors for local recurrence and metastases. It was stratified by stages for surgical management. For malignant tumors, required non-block radical wider marginal excision, and then for the benign, curettage intralesional. And it provided guidelines for adjuvant therapy. In 1988, Enneking said the surgeon must meet two sometimes conflicting goals. One is local control, and the other is preservation of function. The risk of recurrence must be weighed against the benefit of retained function, the availability of adjuvant therapy, and other facts leading to the final choice of the operation. It wasn't really until the 1990s, with the development of the WBB classification, that the Enneking classification was applied to primary spine tumors. And with that, we saw an explosion of en bloc techniques. Fortunately, the long-term outcomes from these showed substantial morbidity and poor local tumor control or cure, and that led us and others to explore the development of effective radiation and systemic strategies potentially associated with equal local tumor control but less morbidity. The en bloc excision is a marvelous technique, but often it's constrained by two factors. One is really the anatomic constraints of achieving an en bloc excision for wide margin required in the malignant tumors such as chordoma. And you can see in this patient who presented with a clumsy hand syndrome and high cervical myelopathy, you're really constrained by the dura, spinal cord, bilateral vertebral arteries, and the posterior pharynx in your attempt to achieve a wide marginal excision. This is a little bit different. In chordoma of the sacrum, we are willing to accept the morbidity of loss of bowel and bladder function. This is a patient who underwent an en bloc excision S2 to the coccyx through a front-back excision. This was en bloc excised for a wide margin. The closest margin was 3 millimeters, and yet at a year we had this metastatic disease. And there are two scenarios for this. One is that there was spillage during surgery, which was not appreciated. But more likely, and known really from the Harvard experience, that there is microscopic disease outside the gross tumor volume in sacral chordoma, particularly in the gluteus and piriformis region, and that leads to these really early recurrences. It's not that you didn't en bloc for wide margins, it's that you didn't account for the microscopic penumbra that's ubiquitous in these types of tumors. And that led to this series of memorial of 43 patients who underwent en bloc excision of tumors in the sacrum. 63% of those resections were for wide margins, versus 37%, even though they were en bloc, they were marginal or intralesional. The 5-year recurrence rates were 66%. And again, a major explanation for this isn't that you couldn't excise for a wide margin, but you couldn't account for microscopic or skip lesions that were already there at the time of the resection. And so the question became, can we achieve local control without a wide en bloc resection or potentially even surgery at all? And it turns out that you can give radiation to ablative doses for chordoma. And much of this was really predicated early on in our experience with metastatic tumors using SBRT. But it's been known for decades that using conventionally fractionated radiation upwards of 70 gray in 1.8 to 2 gray per fraction, that you can affect a chordoma. And then for stereotactic radiosurgery at 24 gray single fraction. And the problem is that spinal cord tolerance is significantly lower than these doses. For conventionally fractionated radiation, the TD55 is 50 gray. And remember, we're trying to get to a 70 gray dose to treat the tumor. And for SBRT using 24 gray or single fraction radiation, the core Dmax is 14 gray, well below ablative doses for radiation. So the question became, can we give a cytotoxic dose to the tumor and spare spinal cord tolerance? And of course, there are a number of strategies that allow you to do this. Both proton beam and carbon ion use the Bragg peak effect. Again, for protons, we're usually using conventionally fractionated radiation. And for carbon ions, hypofractionated, usually 70 gray and 5 gray per fraction. And then there's photon beam, which we're really interested in, using delivery systems such as IGRT or now volumetric arc therapy, where you can give that radiation as conventionally fractionated, 70 gray and 2 gray per fraction. We occasionally will use high-dose hypofractionated radiation, typically for primary tumors, now 50 gray and 10 gray per fraction, or again, this high-dose single fraction 24 gray. And then the question is, if you can give an ablative dose of radiation, how do you apply that? Do you give it as neoadjuvant upfront radiation followed by resection, or as a postoperative boost, or can you, in point of fact, use it as definitive radiation? I think really the first series that looked at the integration of radiation with surgery was from Tom Delaney's group at Mass General, and they'd had a massive and long experience with proton beam therapy. This was a series of 126 patients, both lumbothoracic spinal tumors as well as sacrococcygeal. The mean dose total was 72.4 gray, but they gave a preoperative dose ranging from 19.8 to 50.4 gray, conventionally fractionated. They did a maximal surgical resection followed by a postoperative boost. And in this series, the local control for primary tumors at 5 years was 68% and then fell at 10 years to 52%. The 5-year local control was better if they did an en bloc resection versus intralesional. But radiation therapy also, regardless of the type of resection, was significantly better than if the patient did not receive radiation therapy. Very meaningfully in this series, the patients with primary chordomas who underwent this preoperative radiation followed by an en bloc resection and then this postoperative RT boost had no evidence of recurrence in any of those patients. So again, compared to our series of chordoma in the sacrum, where we had about a 60% recurrence rate, if you did an en bloc excision with radiation, potentially you could cure those patients virtually in 100%. The big problem with preoperative proton beam radiation is the wound infection and dehiscence rate. There's a massive amount of radiation that actually goes to target. So while none of the viscera gets any radiation potentially, the bigger problem is that to target, you have about a 30% decrement in radiation delivery. So there's a massive dose to the skin. And even using VRAM flaps, they had significant issues with wound infection and dehiscence. One of the great strategies and improvements, which Bernard Meyer is going to talk about in a little bit, is if you're going to do surgery for a primary tumor and you intend to use proton beam or carbon ion, any of the charged particle radiation, it's probably better to use peak carbon fiber fixation, which really does not impact the dosimetry or dose delivery, as opposed to titanium or other materials. What was really interesting to us, too, was how much did the radiation actually impact tumor control, potentially versus resection. And this was also a series of patients from Mass General, 40 patients who had unresectable chordoma. They got a median dose of 77 gray and 2 gray per fraction, and their 5-year local disease control, again, in patients with unresectable chordoma, was 85.4%. So again, you start to see that this radiation can be really impactful for tumors like chordoma. Here's a series of carbon ions from several years ago from Japan, looking at 34 patients who got carbon ion radiation, again, around 70 gray and 5 gray per fraction. And they demonstrated 94% local control at 5 years. In subsequent series, this has fallen to about 85% local control. But again, using definitive radiation with carbon ions for sacral tumors has really been a significant advance over potentially doing an en bloc resection with the incumbent morbidity. And again, they do have skin toxicity issues with this, but the local control rates are superb. Early on, we really got interested in photon beam therapy, stereotactic body radiotherapy, and we're now looking more and more at proton therapy for these patients. But our initial experience was really with photons for chordoma. Our original patient had an L3 chordoma, and he was unresectable, certainly for an en bloc resection based on age. And so we gave 24 gray single fraction. At 2 months, we biopsied him and kyphoplastied him for a fracture, and there was still a viable tumor. At 4 years, there were radiographic changes that we thought were suggestive of progression of tumor. And we went in and intralesional resected the tumor, and it was 99.9% necrotic. So essentially, again, you can give an ablative dose of radiation with radiosurgery. That led us to the series of 35 patients who presented with de novo chordoma, the mobile spine and sacrum, who received their initial treatment at Memorial with single fraction radiation. In this series, A third of them, half of them were in the mobile spine, and half of them were in the sacrum. As far as the surgery, a third of them underwent intralesional resection, either simple separation surgery or curettage, gross total resection. A third of them underwent en bloc resection, specifically 10 of the chordomas of the sacrum. And then a third of them had no surgery, got definitive radiation. In terms of the intent and timing of radiation, again, a third of them got neoadjuvant radiation, a third postoperative radiation, and a third it was used as definitive radiation with no surgery. In terms of our local recurrence-free survival, the overall 5-year local recurrence-free survival was 80%. If they got 24 gray single fraction, it was almost 90%. Again, the 24 gray patients had a 5-year local recurrence-free survival of 90%, and that was irrespective of other treatment. So it didn't matter whether they got an intralesional separation surgery or gross total resection, whether they got it as a postoperative adjuvant following en bloc resection, or whether they got it as definitive radiation. 24 gray single fraction was the number that gave us 90% local control, regardless of what treatment they got from that. So again, we're giving an ablative dose of radiation to these patients. And that led us to the concept that SRS may be an alternate to en bloc or attempted en bloc resection, and it may provide a potentially curative treatment when aggressive surgery is not possible. The surgical complications in this series were most related to en bloc resection of sacral chordoma. Now, there are radiation toxicities as well. Most of them are grade 1 and 2. The grade 3 toxicities were mostly fixable with local treatment. The one that is really vexing to us is we did have a secondary malignancy, a rhabdomyosarcoma, in a massive sacral tumor that was irradiated as definitive radiation. So we're not out of that spectrum of having delayed secondary malignancies, and we continue to follow these patients to ensure that this is really a relatively isolated event and not something that we're going to see in a large number of these patients going forward. Here are some case examples. This is a patient who had a distal sacral chordoma, got 24 gray single fraction, and you can see this response 4 months after the radiation surgery, and this ended up being durable tumor control. For patients like that with sacral chordomas, they often have an extracompartmental component of the tumor that extends into the pelvis, and the bowel can be plastered to the tumor anteriorly. Josh Yamada was the one who really came up with the idea of organ displacement, much as they do for prostate cancer. And now if the bowel is approximated to the tumor, they'll put saline boluses into the retroperitoneum, and they can displace the bowel 4 or 5 centimeters away from the tumor to make a better target for the radiation within the constraints of bowel toxicity. The other problem we've had in this term is really at the cervicothoracic junction with the esophagus. And now this was a chordoma that had a little bit of expansion outside of the bone, abutting the esophagus. Thoracic surgeons will now go in and put hydrogel spacers between the tumor and the esophagus, giving, again, a better target for the radiation within constraints of esophageal toxicity. The spinal cord is the one organ, obviously, that we can't displace. This was a 57-year-old female with a 6-month history of hand clumsiness. She had C5-6 vertebral body disease with high-grade cord compression, as you can see here. Didn't think this was a candidate for en bloc resection for this chordoma, so we did an intralesional gross total resection, followed by 24 gray single fraction. This postoperative image is seen in panel B. This is the 5-year follow-up film after 24 gray single fraction and intralesional resection with no evidence of residual or recurrent tumor. Here's a 53-year-old football coach who presented with high-grade cord compression and significant myelopathy with lower extremity weakness and numbness, came in requiring ambulation with a walker. He came into one of our partner hospitals in Connecticut and was taken emergently for separation surgery, and this tumor ended up being a chordoma. You can see the tumor here with 2-level epidural disease and vertebral body disease, single segment, and you can see the degree of high-grade cord compression. There was no diagnosis at the time they took him to surgery, but they operated on him for neurologic salvage. And I would tell you that even if you knew that this were chordoma, you're not going to get a negative margin resection on this tumor, and ultimately the radiation is going to be your best way to control tumor in this setting. Now, they took out this tumor and they got neurologic recovery, so they did a brilliant job of the surgery, and certainly for metastatic disease would have been a very good operation. The problem is we still had too much compression to give what we like to give in these cases is 24 gray single fraction. So we took them back for a reoperation to give a bigger target around the thecal sac, this 2 millimeter margin that allows us to give 24 gray to the epidural margin and give an ablative dose to the entire tumor volume. Got 24 gray single fraction. The other issue with this is that this is a very good construct for metastatic disease, but really not going to be a durable construct for a primary bone tumor. And so we took them back, re-instrumented them with cement augmented screws. We did vertebroplasty or kyphoplasty at the level of the surgery without resecting this vertebral body. And in this case, we actually did a vascularized rib graft that we rotated over the transverse processes and then used autologous ileus grafts on the contralateral side. Here's his 2-year follow-up film with no evidence of residual or recurrent tumor. So again, he had simple separation surgery, and then we used the radiation as we do with metastatic disease to get local tumor control. And here's that patient that I presented initially, 54-year-old female with a high cervical myelopathy, clumsy hand syndrome, had this chordoma at C2 with high-grade cord compression, bilateral vertebral artery involvement, and tumor extending into the posterior pharynx. Again, in this case, they're not a candidate for en bloc resection, certainly for wide or even marginal margins. So we took this patient for simple separation surgery, which you can see here. We reconstituted the thecal sac, but left all this tumor around the vertebral artery and pharynx behind. We gave 24 gray single fraction. Here's a 7-year follow-up film with no evidence of residual or recurrent tumor. Now, one of the standards that people go by to determine that you should use an en bloc resection for chordoma is a series from the AO Spine Knowledge Forum published in JNS Spine. And what they showed was that if you did an en bloc resection, you had a significantly better chance than intralesional. So the en bloc was the Enneking appropriate, where they only had a 14% recurrence rate, versus Enneking inappropriate, where it was upwards of 50%. Now, interestingly, in this series, adjuvant radiation ended up being a negative prognostic variable. So if you got radiation, there was a much higher chance of recurrence. And the problem that there are multiple problems, at least as far as we see it with the series, but one of those is they couldn't delineate what kind of radiation and what dosing, and obviously that makes a difference. In terms of their outcomes for recurrence, the patients who got an Enneking appropriate en bloc for wider marginal margins in this case had significantly better local tumor control, lower recurrence rates than patients who underwent an en bloc, underwent an Enneking inappropriate or intralesional resection. What we have seen with the integration of effective radiation is that we can actually pull this curve down. So with the addition of radiosurgery, particularly at that dose of 24 gray single fraction, again, regardless of whether they had an Enneking appropriate en bloc resection or an intralesional resection, or even as definitive radiation with no resection, we've actually pulled this curve at least equal and perhaps even below, trying to do these massive, these massive operations with a lot of morbidity and neurologic decline. And so at least in our sense that the radiosurgery has a very effective strategy and needs to be integrated in some way into the treatment paradigms for these tumors. Question is, does it work for chondrosarcoma? And the reason I mention this, I think the really early series from Boreani, the first series to show that en bloc for tumors was significantly better than intralesional, was the original series from Stefano Boreani. And I happened to be in clinic this week and saw 2 long-term chondrosarcoma patients, both of whom underwent intralesional resection. This for a chondrosarcoma in the cervical spine with 3-level epidural disease. We did an intralesional gross total resection on this patient, followed by 24 gray single fraction. Here's a 12-year follow-up film with no evidence of residual or recurrent tumor. And here's an intermediate grade chondrosarcoma operated in 2013 with high-grade circumferential epidural disease and myelopathy that we resected, gave 24 gray single fraction. and here's a 10-year follow-up film with no evidence of residual or recurrent tumor. We're going to go back and look at our chondrosarcoma series, but I think in large part, we're probably going to be able to refute that idea that chondrosarcomas too are not radiosensitive to high enough dose, either SBRT or protons, and begin to integrate those, especially in patients who are not candidate for en bloc surgery for cure. I think that chordoma is a lot like killing a New York City roach. You can either use a can of Raid, which is very targeted, like separation surgery followed by SBRT, and you have a very high probability of killing the roach without doing significant damage to the rest of your house. Or like en bloc resection, you can use an atom bomb to kill a roach. You may or may not kill the roach ultimately, but you're definitely going to have a lot of morbidity and a lot of collateral damage. I think the tides are largely changing. I think we're now looking at the rational integration of radiation to treatment paradigms for primary bone tumors, particularly chordoma and chondrosarcoma. I think there are a number of avenues of evidence that these tides are changing. Stefano Boriani of WBB classification fame no longer does en bloc sacrectomy in lieu of carbon ions, which they now have available in Italy. There's a sacral randomized controlled trial comparing en bloc resection versus proton beam in Europe, and they can get no accrual in the en bloc resection arm. And then I think in the joint section debates, we've done this now a couple of times, and I think debates are really bad forums because people have to defend a position. And I think largely en bloc versus rational integration of radiation, it's a spectrum that we're really working hard to figure out the optimal treatment. In 2004, Z and I debated this. Gukaslan won in a knockout. It wasn't even close. The commentary I got was, I had some good shots in, but it was way too theoretical. We redid this debate in 2018. I won on 2 out of 3 of the cards in the vote. Gukaslan was masterful as usual, but at this point, data is data, and you have to appreciate what's coming out in the radiation domain. I suspect they're going to ask us to do this again in 14 years, so it'll be a rematch in the Cahill debates. I think the debate will largely be predicated at that point. It's going to be a draw regarding not whether surgery is important, but what radiation technique and dosing, which biologic checkpoint inhibitor and or vaccine should you use. And en bloc resection will be presented somewhat as a historical footnote. And somebody heard an attendee walking out in that 14 years and said, did I hear that right? Did we ever really do that? And with that, I end, and I thank you very much for your attention.
That was brilliant, absolutely brilliant. Thank you. And I love that tides are changing slide with a prediction of 2023 matchup and en bloc resections, the vaunted highlight of maximum surgical complexity being an afterthought. Let me run a case by you that I had a couple of years ago. We had one of those weird C2 lesions, look pretty bad, unstable, fractured, and a physician's spouse, and we stabilized her from the back, and I went in from the front. The whole anterior part was not amenable with needle biopsy. We did a extensile exposure and resected. The lesion got intraoperative biopsy, confirmation that this was likely a breast CA. Under that premise, we did not resect the lateral mass, which encased the vertebral artery fully. I did an allograft reconstruction, and we were happy. We're going to rely on radiation. Turns out it is a chordoma after all. I think your center got some specimens also. There was multiple centers involved in that decision-making. I was obviously pretty despondent about this change in pathology, which would have changed my surgical resection. So now we have a setting, we have a chordoma diagnosis. I did a subtotal resection. Structure of the patient is great. What radiation should I use and when should I start that? So it's a practical scenario, but this is not that uncommon. We have subtotal resection of a chordoma that would have not been totally resectable. And we now want to look at adjuvant radiation. What's your advice? The patient has unlimited means.
Yeah, I don't see, is Josh Yamato on? I'm going to defer to him. I think you have really 2 choices. I think you can do really single fraction radiation for a limited disease in that area is a remarkably effective adjuvant. Especially in the cervical spine where we're still using a lot of titanium, proton beams are maybe not as as reliable in the radiation delivery. So I think, single dose photon beam, they're not comfortable with that. A lot of times now for the bigger tumors, but also in areas where you need to improve the therapeutic window, that you have to protect your spinal cord and your radiation oncologists aren't comfortable. Largely now we're having pretty good success with 10 gray times 5. And so they can do hypofractionated radiation. The target for the radiation, though, remember, is not the residual disease. It's the original tumor volume. So you have to treat that entire, whatever is, we would agree with to not resect around the vertebral artery. There's no reason to risk that, but your tumor volume is the original where the tumor was. And so, but it's been remarkably effective in ways that we never imagined. But it's exactly using those scenarios where we just had somebody sent from upstate who had 2 biopsies negative, ended up resecting for high grade, ended up being chordoma, and the patient was despondent over that. And the only thing I can say is it seems like it's salvageable in those situations to use, high dose conformal photons, no different from what we're doing in solid tumor malignancies that are equally radioresistant to conventional radiation. You can salvage those patients with hypofractionated radiation, seemingly at the same rate that we do in any other solid tumor malignancy, and it seems to be durable.
This patient actually came to your center and had exactly done what you just talked about, and she did remarkably well. And it was fortuitous that I used an all allograft anterior column reconstruction from her C1 down. So that did make the life of radiation oncologists easier. But you guys were fantastic. I want to really shout out to you and your teammates.
Yeah.
For excellent advice. I know she healed her allograft beautifully, and at 2 years, her MRI and CT follow-up showed no disease progression. There's still that lateral mass vertebral artery casing sitting laterally, but without any change in size or virulence. So thank you for that direct thing.
Oh no, I'm so glad. Thank you for sending it. And yeah, Josh is kind of the genius, and I think he was brave. And it's like everything else. You do the couple of cases that are undoable any other way, and then you realize how good it is, and then you can start to apply it more broadly. So thank you for sharing that for sure.
Dr. Mendel or Askuyan?
Hey, Mark, I marked on my calendar the year 2032. I can't wait for that for that one-on-one between you and Zia. I gotta give it to you. You are that kind of guy who just push the limits and the norms continuously, and it's incredible, right? To be able to get to the point where you start showing some of this data, and it goes against every fiber of what we typically believe in, and so you're the one who really is just willing to take those challenges and challenge the norms, which is so important.
Thank you, Udi. I think it's such a tribute to having a group, that has worked on this and watched these patients together for so long. And I think Josh is next, but it's really Josh Yamada is incredibly inventive and brilliant, and we didn't have an ego, but most of these patients, even you would look at them and say, I can't do this. There's no way to do something meaningful for them. And so you start looking for other solutions. I think the bigger one now, and I don't know if he's going to share this data, but we had a protocol for recurrence with Nevo radiation, and I haven't seen the data. He says it's excellent, but these tend to be, for whatever, immunogenic in a way. And so we think there's lots of ways to start to integrate that too. And I think you'll start to see that, there's lots of protocols for immunotherapy, but I think there's going to be ways to integrate all these newer, biologic checkpoint inhibitors, vaccines, whatever. It'll get better and better. But thank you for that. But I think, necessity is the mother of invention, right? Or integration. And I think that's exactly right.
You guys, it's interesting, the idea of putting those hydrogels and pushing the esophagus out of the way. Is that something common that's done in other centers that do radiosurgery? Or is that something unique that you guys have developed to minimize esophageal issues and things like that?
It's a Josh thing. I think the first one, I think because prostate was using it to displace, they were very comfortable doing it for the sacral tumors. We've had probably 4 grade 4 toxicities with esophageal perforation, mostly at cervicothoracic junction. And it almost doesn't matter what dose and how much sparing you are. And so we had to come up with a solution for that. And we have 3 esophageal surgeons here, and they were really amenable to, to helping. And so they'll put a scope in, displace the esophagus. The hydrogel lasts, I think, a month to 6 weeks. So between planning and treatment, it's not an issue. And it seems to have solved that problem. We're even doing that now somewhat for the metastatic tumors too. It's just a really high risk zone in terms of photon beam radiation.
Great. Thank you.
Thank you.